All right, it's time for our Kegel exercises, Twila.
Yes, it is.
And so why do we do our Kegels? Well, it's important for our pelvic health for both men and women. These exercises help support our pelvic organs in women, the bladder, the vagina, the rectum, the urethra. And for some people, it can actually improve sexual functioning. Some people say it makes orgasms more intense and more frequent.
Well, I think that's a good enough reason to do them right
Nobody's going to
there.
argue with that, I don't think. So let's go ahead and do it.
Okay. 3
Times a day.
6
Days a week.
9
Seconds per Kegel.
and 12.
Kegels in a row to make a rep. It's so easy. Just do 12 of these 3 times a day. When you're doing them, hold it for 9 seconds. You will be the envy of your neighborhood. You will have a pelvic floor like a chain link fence, so you will be able to pull a trailer.
If you so choose. And don't forget, you can always go to the GynoCast Facebook page and get an infographic, which kind of details out the customizable plan. You can print it out, put it on your fridge. You can put it up in your office. We can share it with your friends. And it's a great resource to have. So
Indeed.
Make sure that you go and do your exercises today.
Yes.
Stay tuned.
Hello, everyone. This is Dr. Eric Heegaard, and you are listening to the GynoCast.
I'm Twila.
Hello. I kind of took the air out of the room, didn't I?
No, you did just fine. I'm Twila.
Thank you.
No worries.
So, I know that you feel like we have not done as good a job at introducing ourselves as perhaps we should have.
Yeah, we have not.
So, let me just say again. My name is Dr. Eric Heegaard. This is Twila Dang. This is the GynoCast. If you are new to the GynoCast, thank you so much for joining us. If you have listened before, welcome back. And what do we do on the show? What is the whole point?
We talk about anything and everything women's emotional and physical health and well-being.
That's right, and we do it well.
Yes, we
and
do.
We talk about subjects that people really need to know about and want to know about, but sometimes they just don't know where to go. You know, you may not want to talk about some of these subjects in polite company, over cocktails, at work, over spinach dip. If you know what I'm saying.
Well, unless you're me.
Unless they're you.
Well, at this point...
You have a circle of friends that will...
Well, no, at this point I've been doing this job long enough that people tend to sort of drop that veil with me. So now they feel comfortable talking to me about things that I think they would have never talked to me about before.
Well, that is so... I love hearing that because we need to lift the veil off all these topics. If people don't talk about them, people suffer in silence, and there's been too much of that, and it's gone on for too long.
I agree.
So say I.
I would just say the caveat is, why don't you talk to me about it maybe after dinner?
There you go.
Not before.
Okay. And the other thing is, don't Google gynocasto. I'm waiting for, I keep trying to figure out.
That part's not going to catch on the way you want it to. But I do agree. We don't Google. Get your information, particularly medical information, from a reputable source. The GynoCast is a great place to start. Dr. E
it's not the place to start. It's the only place to go. I mean, don't go anywhere else for any of your medical information but here.
Somebody's feeling very confident today, and I like it.
I know. I'm just bursting out of my seams today.
I'd just say take his advice over mine. Remember, I'm just the big mouth girl with opinions. I'm here to facilitate the conversation.
You are.
Yeah, so that's okay.
Okay, so we're going to talk about one of these topics, again, that is very common and really causes a lot of suffering for many people. That is urinary incontinence.
Okay.
And,
you should tell the folks what that is.
Well, I will. Actually, and what I'm going to do is I'm going to let our guest tell us what that is.
Absolutely.
So let me introduce our guest. This is Dr. Eric English. He is a board-certified urogynecologist here at OB/GYN West. This is his specialty, urinary incontinence, prolapse, etc. And so thank you so much for joining us today, Dr. English.
Boy, thanks for having me out, guys. Twila, good to see you again.
Indeed.
Heegaard I see all the time. But Twila, I do enjoy
But it's a pleasure
on.
anyway, right?
It is. It is.
No pressure. This is a fun environment.
And I got to say, I've worked with you all day, and it's a pleasure to work with you some more.
It still is.
It really is.
We work
still
together.
is.
Just as,
Even keep going.
let's go out and have some ribs after this. What do you say?
It's millet time.
Well, let's kind of jump into it. So I think that many people know what urinary incontinence is, but let's get the definition.
The definition of urinary incontinence is uncontrolled leakage of urine that is a problem for you. Some people leak urine, it's not a problem, or they deal with it. And until it's a problem for you, a lot of the treatments honestly aren't even going to interest you.
Yep.
Wait till it's a problem. But a ton of people suffer from this.
I was doing a little research before the show, and I saw that there's a huge kind of breadth of numbers here, but I saw anywhere from 15 to almost 70% of women will experience some incontinence.
Correct.
Periodically.
In fact, a lot of times, because I subspecialized, I will ask people just at a regular annual exam, they'll say, well, I leak sub, but it's not really a problem, or I don't wear a pad, so it doesn't really count. But a lot of people do have problems.
And so one of the things I want to do with all our podcasts is come up with a few things that we will address, and then we'll circle back at the end of the podcast. But a few questions I want to ask you is it normal to leak? Is it inevitable? And is it treatable? So
it depends on how you define normal. It's not the way the system was originally, designed, obviously, but a lot of people do suffer from it. And then your other question, is it inevitable? No, it's not inevitable. And can you do something about it or treat it? Yes. And some of the treatments don't work for everybody. It depends on how the severity of condition. Let's say a lot of you older folks will have patients in nursing homes. They're not going to qualify for some of the most advanced cares, but
Right.
the broad swath of people, there are options for you.
And for the most part, it's very treatable, and there are great treatments available.
Low risk treatments, actually.
Well, that's even better. So why don't we talk about, and there are different types. And so there's not just the urinary incontinence, as you mentioned, the involuntary loss of urine that is causing you problems. But it's not just one thing. Can you take us through that?
Yes. There is stress incontinence, which is very common in people who have had kids. It's a support defect. And when you add any kind of pressure to your abdominal cavity by bearing down, coughing, laughing, you leak urine. It's a structural problem.
So this is, let me just interrupt you.
Go ahead.
I'm going to just interrupt you. And I hope I don't, break your
Train of
groove
thought.
here.
No,
I believe in you, though.
I'm easy.
But this would be the perfect example, is like what I would call the trampoline test.
Yes.
Yeah.
Yes.
Would you agree with that?
Correct.
Mm-hmm.
This would be, someone would say, well, I don't even jump on the trampoline anymore because I leak.
Right.
Twila, it sounds like you know
I have
what I'm
not had
talking
that.
about.
No, I haven't had that problem, but I'm going to disclose. And one of my other co-hosts on another podcast, bless her, she tells the story, so I know I can tell it. She and I were doing a remote for the radio station, and it was at one of those jump zone places.
Right.
And we were like, they were like, why don't you jump on there? We'll take a video. It'd be great. So I don't do these things. I'm not that girl. So she was like, I'll do it. And she ran out and she jumped on the trampoline, and she literally came off the trampoline 5 minutes later and said, oh my God.
Do you have a coat I can wrap around?
Yeah, she was like, I had a leak. I have to go. I'll be back. I have to go to the bathroom. I have to fix this. And I was like, what are you talking about? And then she came back. She was like, I shouldn't have jumped so high on the trampoline. And that's exactly what happened. And we can laugh about it now because it was, at the time, it was just like, thank heavens she doesn't have a filter and things don't embarrass her, because I would have probably been hiding under my car in the parking lot.
True.
But yeah, that was, so I know what you're talking about in that instance.
So as you're saying, this is coughing, laughing, sneezing, lifting, running,
Right.
jumping, trampolining.
Right.
Trampolining.
So when you say
verb?
this is that it's stress, and so it's literally the combination of, we went through a lot down there having children.
Yeah.
And so is this something that, is it even sort of dictated by lifestyle after you have children?
It can be. There's a bunch of factors that filter into it. Sometimes it's weight makes it worse. So just losing weight can make it better then. Other people have a kind of a genetic predisposition to weak fabric, and they'll continue. Or connective tissue is the medical term, but it'll degrade, and there's not a lot that can be done naturally, I guess. Other people, if they have a slight defect, they can do exercises, help build it up, just with musculature, but the structure is damaged. And childbirth does it the most, but even some people that don't have children at all, there was
Get
a
it
nun
anyway,
for once,
right?
they get it anyway.
Do you sometimes, and I hope I don't get any trouble with this, but I'm going to say it anyway.
Okay.
I think it's kind of a bad design. I think there's a design flaw, and I would like to complain
There is.
to the creator of the universe, however you define her to be.
Listen, just get in line behind me. You already know I think this is patently unfair, all the stuff my body has to go through compared to dudes. I'm already annoyed by the design in general.
So this, okay, and I know, Doctor, just hang with us here because we're just going to.
I'm hanging.
Do other animals have stress? Do orangutans get stress urinary incontinence? And they have lots of babies.
I would think that they would, although evolutionarily, your point's valid. We stand up, and in general, the forces of gravity, coughing, sneezing, etc., they drag down through the outlet of the pelvis, and they put undue pressure in an area that probably didn't get as much pressure when we were
On all fours.
quadrupeds, right?
Yeah, we should have never. Well, there's a lot of advantages to being bipedal.
I agree.
Okay,
Y'all
so
got real egghead right
got-
now.
yeah,
I'm
we-
just going to say.
don't you love that word bipedal?
I do, but I feel like a bunch of people just
Quadrupedal?
paused the podcast to go look it up. Just going to say it.
Okay, well, do that.
I mean, I have a college degree, and even I was like, let me go in the
God, that
Rolodex for a
makes it sound
second.
So now, would you say that stress urinary incontinence is the most common type?
Yeah.
So that's the predominant complaint that women have.
Right.
Okay, so we got number one. How about
Number
Number
two
two.
is urgent incontinence or urgency incontinence, and it relates more to a spastic bladder that it gives you a sense that, okay, you have to go, and you may have a normal continence mechanism in other ways, but that bladder will contract, open up that urethra, and force urine out.
So it's like your bladder has a mind of its own.
It's the gotta go entity of incontinence.
Oh, that's not cool.
No, yeah, it's usually neurogenic. Some people, if you have a bad UTI, there could be irritating stimulus, and then you're going. But it's where you just can't control it, and you have the normal sensation, but rapid voiding.
And I've had people say that this might be a typical sort of complaint people have, which is they're just cruising along, but they certain things might trigger it. For example, I don't know if you've had this happen, but for example, someone will say, I reach for my keys to open my door at the end of the day, and that simple act triggers this intense need to go to the bathroom. And
So is
they're-
it like almost like Pavlov's dog?
Yes.
Like I'm in my garage. I gotta go pee right now.
Exactly right, Twila.
Okay.
In fact, they call it key and lock, or people say they have the garage door opener. And that trigger, they know they're coming home. It registers in their deeper parts of their brain, the micturition centers in the pons, and your bladder lets loose, and it's out of your control, involuntary.
Now, my recollection is that for some people this can be very different than stress urinary incontinence, in that in stress urinary you can leak just a little bit, whereas with urgency sometimes you can just empty your whole bladder. Is that correct?
A lot of people, that's exactly what happens.
And that is that's terrible.
Right.
So but this is this? I mean, would this be considered something that's more in your head, or is it? I mean,
there are it can originate from different areas. The key and the lock is brainstem, and then there's they believe like a lower pelvic nerve dysfunction, the S3. Without getting into too great a detail, there's like a reflex, like you know how you put your hand on a hot stove and the hand immediately pulls away without you really thinking about it. There's that kind, and then there's the kind where your brain has much more control and input, like key and lock, like we were talking about.
And that
Wow.
and to me it seems like in some ways that could be almost more disabling in a way than the stress urinary incontinence, because
It is.
It can be, being able to control our bladders and our bowels is a major part of developmental growth as people, and we, in terms of socialization, we do not want to leak urine or stool, for that matter, when we don't want to.
no, of course not.
I don't know if we ever
It's
really want to, but
embarrassing.
Yeah.
Yeah, it's dirty. Then wherever you were is kind of, there's a mess there. I had a 95-year-old who was pretty independent and in good shape taking the bus. She started to leak urine, and the bus stopped going out.
yeah, that's right.
That's not
So they can
good.
be isolated.
Yes.
Yeah.
So those are the two. Would you say those are the predominant?
Major ones.
And then there's mixed, right, which is kind of a combination of both. And
Yeah, which is it's still a major category, but you have urgent continence, but there's a stress component too because you had the 4 kids as well, or whatever. There's also neurogenic incontinence,
which
like,
means just nerve related. It has to do with the nerve.
yeah, spinal cord injury people and dysfunctions relating to severing of some of the nervous control mechanisms of the bladder, and there's obstructive uropathies. There's some minor other subsets out of that, but stress and urge
Are the main ones.
are the ones.
Well, so let's. I'd like to concentrate on that today. So
Yeah.
let's. Could you take us through kind of a normal evaluation for a patient coming in, and maybe I think the basic questions that you would ask in the physical exam, et cetera, would probably apply to both of these different types of incontinence. Could you just tell us what would happen? A patient comes in complaining of incontinence.
Yeah.
How do you evaluate her, and where do you, and take us through the process?
Yeah, we look at their age, general health, medications. We'll ask them questions about the incontinence to help elucidate or help us with the diagnosis. It's not perfect, but it helps us.
Do you ever ask if they're bipedal versus quadrupedal?
I have not. No, I have not. There's a number of assumptions I make.
That's a freebie. That's a freebie for me to get.
No, I say, does it happen?
Bipedal.
Yeah.
Egghead. I just want to see what Twila.
Just gonna keep calling you egghead today.
No, say like, do you leak when you cough? Which sounds like it's straight up stress, but some people, the cough stimulus makes their bladder spasm. So it can be the other one too. It gets tricky. But see how many kids they have. Ask them if it's a short burst versus the whole bladder emptying. We ask them if they wear pads, and don't be ashamed to say you do. Some people have to get up multiple times at night. That suggests irritation problems, part of the reflex arcs I'm describing. And we basically run through a series of questions trying to ascertain and get a better sense of which track they're going down. And then we'll check them usually with either a quick in-office urine test to see if there's a potential for infection. That may roll up then into a urine culture. And because there are a number of people, older folks, that are just very prone to infection. All they need is a very cheap antibiotic, and the problem's solved.
Right.
And that's not incontinence in the classic stress urge. That's just a bladder infection that's irritating your bladder.
But but that's one of those kind of basic things you want to make sure that you're not missing something stupid.
Right.
Easily treatable and
right. So some people are on medication, for example. A common one for blood pressure increases your urine amount so substantially that it overwhelms people's ability to store urine. And those folks sometimes will change their medication for high blood pressure. So we're not using what's called the diuretic class of medicines, or medicines that make you want to urinate a lot or purge fluid.
Oh.
And so then will you generally do a physical exam at the evaluation as well?
Yeah, pretty simple pelvic exam. And we just double check visually what the support is, see if the bladder's tender, because other conditions can cause discomfort that are treated in other ways. But yeah, we do.
And you also specialize in prolapse and that sort of thing, and sometimes this can all go together as well.
It a lot of times does, frankly. And people are just unaware of it. The vagina doesn't have a number of nerve endings, so they can't sense that things have actually continued to fall down progressively over time. But we had a lady today, her cervix was just barely inside the opening. It's supposed to be 4.5 inches back. And she's just now coming to awareness of it. So, yeah, we do. We take a look at the whole system to make sure we're making the right call.
Okay, wait. I'm talking for the audience. Prolapse?
Okay, so by the way, please go and look for our other podcast because we're going to be talking about pelvic floor prolapse in a different show.
Yes.
And prolapse, well, doctor, go ahead and take
prolapse is it's another structural defect that is common and happens, but different components of vaginal support will break down in a number of women and result in the tissues of the vagina and the uterus actually almost like a sock turning inside out, coming out through the opening, sometimes all the way out.
Why do I feel like sometimes y'all tell me these things? I'm the only girl in here, so then I just immediately start panicking.
Yeah, well, you start to think, that's
I'm already this is
kind of nervous laughter.
Yeah, this show is already like the holy grail of crap, this is probably going to happen to me. Now I'm going to spend the rest of my night stressed out. I'm middle aged. I have had 3 children. I had natural births. I at some point had stress incontinence.
Yeah. Well, we're going to talk about what you can do within reason to prevent some of this stuff.
Okay,
and
that would
many
be good.
Of you can't. Yeah. But so you're going through your evaluation, and is there any other testing that you do sometimes with these people?
Usually, we will set them up for an additional test called urodynamics, which is the diagnostic test. And if we don't find one of these other offshoots that are a quick treatment, and we do think it's a long-term problem, we'll set them up with urodynamics, it's called, where we put catheters that give us readings and let us know exactly how the nerves are firing, when nerves are firing, how much you can store. We can see the bladder spasms in the case of urge incontinence. We can even calculate leak pressures and how much of a structural support issue you have. It's very informative.
Support for the GynoCast is provided by OBGYN West. OBGYN West provides the highest quality care from compassionate providers, including women's health issues from general sexual health to pregnancy care, childbirth, menopause, and beyond. Whether it's your teen's first annual exam, a new baby's on the way, or you're facing the special challenges of middle age, OBGYN West provides a wide array of services. Their doctors and PAs are trained in virtually every type of OBGYN service and procedure. OBGYN West provides exceptional care for women.
I guess I want to come back to this basic question, which is, after seeing somebody, talking to them, doing their physical exam, and doing urodynamic testing, for example, if necessary, you can pretty much say this is why you're leaking. Is that correct?
Right.
So why don't you take us through some of the you've made the evaluation. Let's start with stress urinary incontinence, because that's the predominant type.
Yeah.
What do you offer these women in terms of treatment options?
Some people, I always offer people, like, look, it's stress incontinence, just so you know what it is. You could do nothing.
Like chill out? 'Cause you're stressed?
Well, no, it's not that kind of stress. It's a physical, a mechanical stress.
Okay.
Actually, good question.
Okay, so it's not emotional stress.
No.
I said that. Just
I'm gonna need the little drum that bump.
Exactly.
Yeah.
We have other options. Some women, if they're postmenopause, they just need estrogen cream to bulk up the tissues around the urethra, and that'll help.
Because low estrogen thins out the tissue around the urethra and the vagina.
It's all steroid responsive stuff, right? Well, in other words, we start with simple stuff and get to more complex. But a second option is Kegel exercises.
Oh.
Well, do we know about Kegels here on the
Gyno
Gyno
Show?
Show?
About Kegels right around here.
So we'll be doing the Gyno Show, GynoCast, custom built Kegel exercises.
Yes,
later
we'll
on
be
the
doing
show.
that.
So okay, I like that.
There's that. Then we'll sometimes offer a pessary device, it's called. It's a latex device that offers support for the urethra that folds up. You can put it in or take it out and clean it on your own. It's almost like a diaphragm, but it's much more firm. And so that'd be a simple fix for some folks.
And what does that
half
do?
Of them like.
How does that work?
It basically prevents the top wall of the vagina from distorting or pushing into the wall. Into the vaginal space, where the neck of the bladder is no longer under the subject of closing pressures, and that's where you get the leakage.
So one of the things I forgot to ask you to kind of go into a little bit more was, you said it's a structural problem. It's an anatomic defect.
Yeah.
And so one of the things that you're going to describe, whether it be things like medications, like the estrogen, or the pessaries or surgery, if need be, are working to correct that structural problem, correct?
Right, to replace it back where it belongs. Yes.
Because my understanding is that what's happening when you talk about stress is that the bladder neck, the urethra, is moving in a way it shouldn't.
Yeah, it's moving to a place where it shouldn't. Normally when someone coughs or sneezes, like, you feel your belly tighten up when you, it'll actually pinch the bladder neck closed at that same moment, which is, people have referred to it as a sphincter. It's not a true sphincter, but there's a squeezing pressure there that keeps urine in. As the bladder prolapses a little bit or slips down and gets out of that zone, that the bladder is the thing being squeezed, not the bladder neck anymore, and it's actually squirting urine out.
Yeah, so you're kind of like squirting a water balloon, or squeezing a water balloon, pushing that stuff out.
Right.
Okay, so estrogen is one of the things you talked about, which can help thicken up the urethra as well as the vagina, and can affect the bladder, I believe, as well. Correct?
Yeah.
And you talked about the pessaries, which are a mechanical way of kind of supporting that bladder neck, correct?
Right. Like I have a lady that she jogs a lot. She only leaks when she runs, and so now when she runs, she puts this pessary in for her run. Other people live with it 24/7, but it's for people with a very slight problem, but nonetheless have a problem.
But who are typical candidates for pessaries? Because that's to me that seems like that's a kind of a unique subset of women who will use a pessary.
Well, hold on. Before you answer that part, can you kind of describe to us what a pessary is? Like, what is it? What does it do?
There's several varieties. They take on several shapes. They're made out of latex, and They get inserted into the vagina. Some look like an umbrella. Some look like a balloon and are inflated like a balloon. Others are discs like a small frisbee. These plastic devices usually have a hinge. So
Some look like donuts.
Correct. There is a donut pessary, a cube. I mean, they have different functions, and I won't get into all the detail for each one, but the easiest ones that people use at home are the more disc-shaped pessaries. Rings with support is what they would be called, and they fold up. You can put them in and put them out yourself as a patient. More advanced pessaries for more advanced prolapse. Almost always you need a doctor, provider, nurse, someone trained to put it in.
Okay.
We see those more commonly in nursing home scenarios where they have skilled nursing available quite often. These foreign entities in the vagina need constant cleaning, otherwise it's not pleasant for anybody.
Can I give a little tidbit?
Sure.
Do it.
Okay, Doctor and Twila, who were the first people to use pessaries?
Egyptians.
God darn it, you know that. Huh? Did you really know that, or
did,
just
I knew
pull
that.
that out?
That
the
was part of
Egyptians
the
did
torture.
everything.
Yeah,
They did. Yeah, they did. I've seen that before.
Well, I am impressed. So it just goes to show you that. This has been going on for
a long time.
And what do you do when something is falling out? You put something in to kind of hold it up.
Well, it just seems like common sense.
So yes, so you get extra points, Doctor. And so the pessary was first described used in the Egyptians, and Hippocrates mentioned the use of half a pomegranate introduced into the vagina in instances of prolapse. So that's half of. I don't know why not a whole pomegranate.
Because all you needed was a half.
I guess all you need is a half.
Waste not, want not.
Exactly.
So and then I'm looking at something else. Somebody describing using a kind of a ball made of strips of linen and filled with wax.
Yeah.
This has been going on for a long time. So pessaries, which can be very, as you said, very, very successful in many ways, have also been around. Probably your great grandmother, if her uterus was falling out, back in 1902, they probably would have used a pessary.
Probably.
That's right.
I would. Well.
And they wouldn't have said a word
no,
about it.
Well, it depends.
Yeah.
Well, it depends. Half my family, one of my great grandmothers, somebody brought her over on a boat. She didn't want to come here, so she probably didn't get that option. My other one that came from England, she probably.
But
had
I will bet you this, Twila. I don't mean to be argumentative, but I'm going to do it anyway.
Go for it.
Is that I don't, people. I bet you, even if she didn't have access to, fabulous medical care, whatever that would be in the 1850s or late 1800s, there would have been people figured out how to manage this. She would have taken something and put it up on her vagina.
I would hope so. It would just depend on There's a lot of things you didn't get when people didn't think you were a person. So
that's true. That is true.
Like I said, but my other grandma, she came from England. She was covered.
She got a good pessary. She got the wax ball with twine.
She got something.
She got something. So anyway, just that sort of thing is fascinating.
It is fascinating how a lot of what we're using today came from, just ingenuity from the past.
Yeah. So for many women who choose to not use pessaries or try them out, there's other options.
Yeah, there are. So 46% of women end up liking the pessary enough to stay with it. We fit it and we get them on, and then some people take to it, some don't. But it's non-surgical, so people do try it if they're afraid of surgery or don't have a major problem.
Can I ask one question about the pessary real quickly? So it's fitted and it's insertable. When you take it out, is there? I mean, in terms of it clean, is it just holding everything in, or is it sort of holding things back, kind of like how the Diva Cup works?
Yes, the ring pessary, that's the one that's easily replaceable. It just kind of holds things up a little bit. Things that hold things back are these bigger cubes, donuts, big things, and so it's a mixture of both. But when you get that degree of prolapse, you should probably move on to other treatments. If you can tolerate surgical intervention, that's what you should do.
Okay.
So if a support mechanism like a pessary or medication doesn't work, where do you go next?
Next, usually we would offer trans suburethral slings, transvaginal slings. And these are...
That sounds... for those people who don't know what slings are, that sounds... Twila, what does a sling make you does that make you feel good, warm, and happy, or does that make you feel?
Anything you're talking about inserting in my body at this point doesn't make me feel happy.
No.
Well,
I need because it sounds
tough.
like something.
It's a tough sell there. Yep.
Yeah.
Well, so describe what that is.
It's a polypropylene mesh hammock. It's a support that, as we talked about earlier with the bladder neck kind of escaping the normal pelvic pressure that in the normal anatomical position, the sling helps restore that, and it'll lift it and support it and put it back where in the area where if you cough or sneeze, it pinches the bladder neck shut.
And is this a huge procedure that you're going to be in the hospital for days and days with? And is it successful?
Yeah, it's pretty much the gold standard of therapy because especially the retropubic slings that we commonly do at OB West, they're retropubic. And, they're 95% success rate is what we see.
Oh, okay.
5-year, 15-year success rates are very good, and that's a good surgery. I mean, if you have a 50-50 chance at something, that's not a good surgery. When you get up 95%, that's fantastic. And your other question was, where do you do it and how involved is it? It literally takes 15 minutes.
Right.
That's all?
Yeah.
Oh.
It's quick.
And it's outpatient, so you're in and out. And
surgery centers.
What's the recovery usually look like?
You're sore. Sometimes people have bruising. Depending on the variety, there's another variant called the obturator sling. You'll have some groin tenderness with those, and they have a slightly lower success rate of 92%. I've stopped doing those for a couple reasons that, I don't know, not everyone's going to agree with me on, because I usually do these with sacral colpopexies or other support procedures in my particular patient population. But just a straight retropubic sling is such a great fix.
Yeah, it's really trying to kind of transform the way that we've managed these patients.
Yeah.
Now, does this sling and this procedure impact anything in the long term? Like if you're getting a sling, will that allow you to go back to normal activity? Will it impact your sex life? Will it, does it affect anything else?
You can go back to normal activity when it's done. Rarely, we should mention the mesh class action lawsuit.
I was going to ask you about that.
Yeah,
many people have heard about it.
It is, yeah. The polypropylene meshes were implicated in a class action lawsuit because the incision in the vagina where we place these devices, sometimes it just does not want to heal together. And in the case of the sling, it's a 1 centimeter square area that puts you at risk. Nationally, I think the FDA wants us to quote a 10% erosion rate. I don't think we see that, do you? I haven't ever seen that. I mean, it happens occasionally, and we'll take that knuckle of sling out. You have to know that that's the case. But normally, this thing is tucked behind essentially your hymenal ring, your midurethral fold. Your partner doesn't feel it, and you don't feel it. The meshes that were a real problem were large transvaginal meshes. So those were a problem.
That's a different animal.
Yeah, it's a lot more involved surgery that not a lot of people are even doing anymore. Okay. So
let's talk a little bit about the urgency incontinence.
Right.
And what are the treatment options for that?
It can be very complicated. It depends. But, I mean, usually we do behavioral therapy. We'll take out bladder irritants from your diet, like citric acid from fruits and some coffee. Caffeine is an irritant. Unusual ones like avocados. We take those things out.
Wait, hold on.
Can you believe it?
Hold on there.
Can you believe it?
Wait, see, this is
That's
the
not right.
problem. Well, see, Dr. English doesn't know. I'm a vegan.
Yeah.
So that, you just eliminated, a third of my diet. Right?
I'll see you in my urgent incontinence clinic.
Well, it doesn't. But it doesn't bother your bladder, though, does it?
I don't
It's
have
going to.
this issue right now, but I have had that. I've had the stress, incontinence is an issue in between having children.
Yeah,
before.
but this is more urgency stuff. Bladder
Okay.
spasm stuff. So
Okay, yeah, so I'm okay because I don't have that going.
Right. Yeah,
I told you now. I'm on high alert. Now I think everything's wrong with me.
I know. Chocolate. I mean, there's some weird things. But we try to take out whatever irritants are irritating. If avocados don't bother you, they can obviously stay in your diet. But some people see a certain degree of benefit from that. We'll do a behavioral modification like timed voiding for some people. It depends on the results of the urodynamics.
Time voiding meaning
Right. You schedule it.
when you decide to urinate.
Right. So I had a teacher that had to watch the kids, did not get a big break. She would try to hold it for 8 hours. By the end of 8 hours, she was so full. And as a natural reflex, she would just let go.
Yeah.
And, if you can talk people out of little behavioral things that they do, sometimes they see great benefit without, again, no medication, no surgery.
Right.
The next step would be medications. There's 2 classes currently. There's anticholinergics, the gotta go, Detrol, Ditropan. They advertise a lot. They're generics. They can cause dry mouth, dry eyes, which is a problem for some folks. There's a newer class called the beta agonist. It's Myrbetriq is the brand name of the medication. You can't have high blood pressure with it. There's a couple downsides to it, but these are medicines basically designed to let the bladder relax and not be so spastic.
And are they fairly effective for?
Honestly, they're not. Actually, the American Healthcare Research Committee or something, a national group, looked at a variety of studies, and the number of voids per day, a normal person is like 8 times a day. These folks void 15 times a day, and with medication they dropped it to 13.
Oh.
I know. I couldn't. It's really sad. It's almost like, why do they make us do this step? But because the side effects and the expense of the medication is not insignificant. But a few people really do benefit from it, so they say try it before we do the more expensive interventional type therapy.
So what would you do? Where would you go then with somebody who either doesn't respond to the medication, is not a candidate for it, or just fails it? What's the next step?
We offer them the next rung of treatment, which is called neuromodulation. One of the more involved forms of neuromodulation will bring you into a cystoscopy, which is a camera inside the bladder with fluid, and we would do 20 injections of Botox along the mid-rung of the bladder to help, again, relax it so it cannot contract so spastically or so effectively.
I remember I had a patient that I referred to you
Right.
that was really was incapacitated by this, and that worked so well for her.
Yeah.
She
Sounds like a
was
broker
cured.
behavior. Yeah.
It was amazing.
Yeah. Some people, the effect lasts a long time. Usually in 8 to 10 months, the Botox effect is worn off. You have new cells, and we'd have to do it again. It's a repeatable thing.
Right.
It's covered by insurance and Medicare, Medicaid, but yeah, you have to be able to catheterize yourself. The biggest downside and the biggest dissatisfier, sometimes the bladder's so relaxed, 8% of the time, you have trouble really voiding.
Right.
So some folks have to catheterize intermittently for a period of time until bladder
Have you
comes back.
found? I'm just thinking of one particular patient of mine who went from one extreme to the other, but she was so happy not to be leaking all the time.
Yeah.
And she had to catheterize herself, but she was thrilled.
Right. Some people just want relief, just a little bit of relief. So the second option is it's something called pretibial nerve stimulation. We put an acupuncture needle just above the inner part of your ankle. We use a little electrical impulse through that. It runs up your nerve, believe it or not, and breaks the reflex arc. It disturbs it at the back of the sacrum, and a lot of people see a great deal of improvement. It's not hard to do. You could have I have a lady with a pacemaker right now who the electricity doesn't bother her. She's not a candidate for surgery, but we're trying to get her to have some relief here with urgency.
And that's a little. I know it's easy for us to say, but that's a little procedure. There's no blood. There's no incisions.
Well, yeah, no, that's. No. I mean, that's surprising that something that simple would give you a result.
It was developed right over here in Minnetonka. It took a number of years for this little company to get a market percentage or whatever, a cut of the market. But it's really great. And so I have a woman that was going 15, 16 times a day. It's been cut in half, and she doesn't have to get up at night, and she's happy.
How long of a process is this? They do it every week, don't they?
Yes, weekly, half hour. It takes us 2 seconds to put these little needles in, but you have to sit there for half an hour while the impulse does its thing. And, come back once a week, 12-week course, and then to maintain the effect, you have to come in once a month.
Okay. Oh.
So it's a little
it's
bit
a little
of an
involved,
but
yeah.
Well, I mean, even if it's a little involved, it's better than the other option. And the other option is suffering.
Right.
It's not just suffering. A lot of these folks, especially as they get older, they're in danger, honestly, of going to nursing homes, which is 40% of people have urge incontinence. Severe urge incontinence, don't have control, and they just can't take care of themselves, their skin, anything on their own.
Can't take care of struggling.
Yeah, it's a burden. So, yeah.
So it goes beyond just the
annoyance of the urine. Right.
Well, I think that's something that we barely think about in terms of some of these issues that come up as we get older and decisions that we have to make, and even this sort of quote unquote sandwich generation that I'm apparently a part of now. that actually, you're right, because that's, my grandmother, before she passed away, that was one of the factors that went into it, is that my mom couldn't take care of her.
Yeah.
And those were some of the issues that we were having, and it was easier to have a professional that could take care of those things. So
yeah, even the expense of these pads, they're expensive.
Yeah.
Oh, $3-4 a pad. If you're leaking through 3-4 pads a day, it adds up on a fixed income.
Mm-hmm.
Right.
Last option is a more permanent. It's like the pretibial nerve stimulation. It's a needle in the back, and we test and evaluate disruption of the sacral nerve on a permanent basis with a pacemaker, and then we'll implant that. That has a battery that lasts about 5 or so years, depending on some of the settings that we use and how much energy is used. It works the best. So if you have people that peep 30 times a day, 5 times at night, they'll go down to 6 or 7 times. It's just absolutely life-changing.
That's right.
It's involved, but it's worth it.
Well, Dr. English, thank you so much for joining us and talking about this. Again, I want to say that if you heard anything from this show, I think you can realize, number one, that incontinence of whatever type is common. So you're not alone. It's not something that people talk about a lot, but it's something that causes a lot of distress and sometimes real disability related to it. It's not inevitable. There are things that we can do to treat it, and you don't have to suffer from this. There's a lot of different options available.
True.
Absolutely.
All right.
Well, as always, make sure that you go to the GynoCast Facebook page. You can go to Facebook, go in the search bar and type in the GynoCast. If you haven't done that already, you should, and you should like the page. You have to request to be a member. It's a private group, but that's only because we have a lot of mature conversations. We talk about difficult topics, and we do it in a very engaging way, and we want to make sure that the people in that group that are having these discussions are approaching it the same way that we're approaching it. So,
that's right.
It's a fantastic group, and it's been well maintained. I've always given Eric a lot of credit for how he maintains the community that's there, and the discourse that is there is always so respectful and encouraging and supportive, and I just want to make sure that we continue to have it be that way.
Yep. Exactly.
So it's super easy. When you go in there, there's a lovely little send message option. If you want to email the show, if you have questions for us, if you want to have comments, feel free to make them out on the main page as well. But if you need a little more anonymity, you can do that as well. And we should point out that anytime we have a show like this that has information and resources, we'll try our best to put a syllabus together for that episode so that you can get a little bit more information. You can find out how to get in touch with Dr. English. You can find out how to get in touch with Dr. E. And you can get a little bit more information about the topic at hand that we discussed today.
That's right. Thank you so much for listening. We'll see you soon.
Thank you.